Okay, let's unpack this. I want you to picture specific scenario.
Okay.
It's a Saturday night, maybe 2:00 a.m. A patient is wheeled into the ER, car crash. They're awake, they're talking, maybe they look a little pale, but, the monitors say they are stable.
The classic walking wounded.
Exactly. But inside, it could be a war zone. You could have a slow leak in the spleen, a nick bowel, something ticking away that you can't see from the outside.
Right.
And in that moment, the most dangerous thing in the room isn't necessarily the injury itself, it's the bottleneck.
The bottleneck. Right, because that patient needs answers, and they need them fast. They get a CT scan,
Yep.
but that scan isn't a magical answer key. It's just data. It goes into a queue.
Right.
And at the other end of that queue is a radiologist who has likely been working for 10 or 12 hours.
Staring at thousands of shades of gray.
Trying to spot a smudge the size of a dime that shouldn't be there.
And the stakes, they couldn't be higher. I was looking at the numbers in the briefing, and they're terrifying.
Yeah.
Trauma is the leading cause of death for people under 45 in the U.S. Globally, it claims 6 million lives a year.
It's a staggering amount of loss.
Right.
And you put your finger right on the pressure point, the human element. We have incredible doctors, but radiologists are scarce.
And they're exhausted.
They're exhausted, and the expectation is that they have to be fast and perfect every single time. A missed diagnosis on a trauma scan isn't an oops.
No, it's potentially fatal.
Exactly.
Which is usually the part of the story where the tech world kicks down the door and screams, AI will save us.
We've heard the pitch a million times.
The robot doctor. But today, we aren't talking about the hype. We are looking at the plumbing. We're going to talk about what it actually takes to build a machine that can survive the chaos of a real trauma center.
Exactly. Because here's the reality. An AI is only as smart as the diet it's fed. If you feed it garbage, you get garbage.
Right.
If you feed it limited data, you get a tool that fails the second things get, weird.
And in the ER, things always get weird. So today, we are doing a deep dive into something called the RATIC Dataset.
RATIC.
That stands for the RSNA Abdominal Traumatic Injury CT Dataset. A bit of a mouthful.
It is, but the pedigree is heavy. This is the Radiological Society of North America, the RSNA teaming up with the American Society of Emergency Radiology and the Society of Abdominal Radiology.
So the heavy hitters.
Basically, yeah. The heavy hitters of the field came together to solve the data problem.
And the mission for this deep dive is to figure out why this specific pile of data is different. Why isn't this just another hard drive full of JPEGs? Why is this specific data set a game changer for saving lives?
Well, to understand that, you have to understand the problem they were trying to fix. I call it the Swiss cheese problem of medical data.
The Swiss cheese problem. Okay, paint the picture for me.
Before RATIC, if you were a researcher trying to train an AI to find, say, a liver bleed, your resources were just full of holes. You'd find a data set from one specific hospital. Or maybe a data set that was huge but only looked at the kidneys or only the spleen.
So it's fragmented.
Completely.
Yeah.
Think of it this way. Imagine you were trying to learn to speak fluent Spanish.
Okay.
But the only textbook you have is a dinner menu from one specific taco stand in Madrid.
I could probably order a taco perfectly.
You could. You'd be great at it. But if someone starts talking about philosophy, or if you travel to Mexico City or Argentina,
I'm lost.
You're lost. You learn a dialect, not the language.
I see. So in AI terms, if a model trains on data from Hospital A, it learns Hospital A's dialect.
Precisely. It learns the quirks of their specific scanners.
Yeah.
It learns that their machine adds a specific type of grain to the image. It learns their specific protocols.
And then you take that AI and drop it into Hospital B.
And it falls apart. The scanner is a different brand, the settings are different, and the model just doesn't generalize. It fails.
So how did the RATIC project solve this? Because fixing data collection sounds like, a logistical nightmare.
They solved it with brute force scale and diversity. The numbers here are just massive. We're talking about 4,274 adult patients.
Wow.
That totals up to 6,481 image series.
That is a lot of scans.
It is. But the size isn't even the most important part. It's the geography.
Right.
They collected this data from 23 distinct institutions across 14 different countries. We are talking about data coming from 6 different continents.
6 continents. So they have scans from Australia, Brazil, Turkey, Canada.
Everywhere. And that geographic diversity is the secret sauce. because different parts of the world practice medicine slightly differently. They have different imaging protocols.
When you say protocols, what does that actually mean for the image?
It's things like slice thickness, so how thick the digital slices of the body are, or crucially, the phase of the scan.
The phase.
Yeah, when you inject contrast dye, it flows through the body over time. If you take the picture at 30 seconds, the arteries light up. If you wait 70 seconds, the organs light up. Some hospitals use what's called a portal venous phase. Others do a split bolus, where they inject twice to see everything at once. If an AI has only ever seen one type,
The other type looks like gibberish.
exactly. So by collecting this messy, diverse, global data, they essentially force the AI to learn in the real world, not just a lab.
They built a gym for the AI that simulates every possible weather condition it might face.
That's a great way to put it, yeah. If it can spot a kidney injury in a grainy scan from a rural hospital in Brazil and a high-res scan from a trauma center in New York, then it's actually ready for the real world.
Okay, so they have the raw material, thousands of scans from around the globe, but you can't just dump raw images into a computer and expect it to learn right.
Not at all.
A raw scan is just a 3D block of pixels. Someone has to tell the computer, hey, that blub right there, that's a lacerated spleen.
Right, this is the annotation phase. And honestly, this is where the sheer human effort of this project is kind of mind-blowing.
You can't crowdsource this.
No, you can't go on a gig app and ask random people to identify internal bleeding.
Select all squares containing a splenic hemorrhage.
Exactly. You need experts. So they assembled a massive team, 43 attending radiologists, so fully qualified, senior doctors, and 2 fellows.
Wow.
These came from 38 different institutions, and crucially, the vast majority were specialists in abdominal or emergency radiology. These are the people who stare at these scans for a living.
That is a lot of expertise in one virtual room. But here's what I'm wondering. Medicine isn't math, right? It's not always 2 + 2 = 4.
Not even close.
Sometimes an injury is obvious, but sometimes it's really subtle. I've heard doctors argue over scans before. How do they decide what is true if the experts disagree?
That is the million-dollar question in medical AI. They used what's called a reference standard based on a majority voting system.
Okay.
Every single solid organ injury was looked at by 3 different radiologists independently.
So they can't influence each other.
Correct. So let's say they are looking at a kidney. Radiologist A says no injury. Radiologist B says grade 2 injury. Radiologist C says grade 2 injury.
2 against 1.
The majority vote is grade 2, so that becomes the ground truth for the AI.
What if they all disagree? Like
Yeah.
one says no, one says mild, one says severe.
In those deadlock cases, an adjudicator, a senior member of the organizing committee, would step in and make the final call.
Ah,
They essentially engineered a system to filter out individual human error or, bias.
that brings up the grading system itself.
Yeah.
I saw in the source material they talked about the AST grading scale. That's the industry standard, right?
It is the American Association for the Surgery of Trauma grading scale. It goes from grade I, which is minor, to grade V, which is catastrophic.
Right.
The problem is, even among experts, there is high inter-rater variability.
Which is a fancy way of saying doctors argue about the specific number a lot.
Constantly. One doctor's grade 2 is another doctor's grade 3. So to make the data cleaner for the AI to learn, the RATIC team did something really smart.
What's that?
They simplified the grades into 2 buckets. Low grade, which captures I, A2, and 3, and high grade, which captures 4 and V.
Why does that simplification help? Is it just making it easier for the computer?
No, it actually mirrors clinical reality. If a patient has a low-grade injury, generally the plan is watch and wait.
Conservative management.
Right. But if it's high grade, that usually means surgery or an immediate intervention like angioembolization.
So they taught the AI to think like a trauma surgeon. The question isn't, is this a 2 or a 3? The question is, do I need to act now?
Exactly. It cuts through the academic noise and focuses on the clinical decision point.
Okay, so we have the data, we have the experts voting on the labels. Now let's talk about the targets. What exactly is this AI being taught to hunt for? Because the abdomen is packed with stuff.
They narrowed it down to the big 5 targets, plus 1 critical condition. The solid organs were the liver, the spleen, and the kidneys, both left and right.
Those are the big, dense organs.
Right. In computer vision terms, they are relatively easier to spot because they have distinct shapes. But then you have the tricky ones, the bowel and the mesentery.
Why are those tricky?
Because unlike a liver, which is a big solid chunk, the bowel is a hollow, twisting tube. It flops around.
It doesn't have a fixed shape.
No. And the mesentery is just the fatty tissue that holds the bowel in place.
So how does an injury even show up there?
It's incredibly subtle. Often, the only sign of injury is a tiny bubble of air outside the tube where it shouldn't be, or a little smear of fluid in the fat. Sometimes the fat just looks misty.
Misty fat.
Teaching a computer to distinguish misty fat from normal fat is a nightmare compared to finding a cracked spleen.
But there's one finding you mentioned that trumps them all. The ticking clock.
Active extravasation.
Active extravasation.
This is the radiologist's worst nightmare.
Break that down for us. What does it look like?
So remember the contrast dye we inject into the blood? It lights up the blood vessels bright white on the scan. Active extravasation means you see that white dye leaking out of the blood vessels and pooling in the abdomen.
So it's active, uncontrolled bleeding.
Exactly. It means a vessel has been torn open. It is a stop everything and fix it emergency.
Right.
If the AI misses a small bruise on the spleen, the patient usually lives. If it misses active extravasation, the patient could bleed out in minutes.
So accurate labeling here is critical. I was looking at the images in the report, specifically Figure 2, and I noticed they didn't just draw a box around the organs. It looked more like a paint-by-numbers picture.
Yes, this is called segmentation. And it's a crucial distinction. In a lot of computer vision, you just put a bounding box, a square, around the object, like there is a cat in this box.
Sure.
But for organs, especially for surgery planning, knowing a kidney is somewhere in this box isn't good enough.
You need to know exactly where the organ starts and stops.
Right. So they used a baseline AI called NNUNet to take a first guess, and then the humans went in and manually corrected it pixel by pixel.
They painted them in.
They painted the liver red, the spleen green, the kidney blue.
That must have taken forever.
It's incredibly labor-intensive. But it teaches the AI the 3D volume and shape of the organs. It helps the AI understand the anatomy in 3D space, which is critical if you ever want to use this for surgical planning later on.
I want to circle back to something you mentioned earlier about the messy real-world data.
Yeah?
The report mentioned wrangling the real world involved some pretty weird technical hurdles.
It did, and one of the weirdest was the z-axis problem.
The z-axis. This sounds like high school geometry coming back to haunt us.
It's simple, really. The z-axis is just the vertical length of the body.
Okay.
When different hospitals scan trauma patients, they don't all scan the same amount of the person. Some hospitals scan from the top of the head all the way down to the feet.
And others just scan the belly button area.
Exactly. And I can see how that would confuse an AI. If it's looking for a spleen and suddenly it's seeing a kneecap or a lung.
It introduces noise.
It introduces noise. The AI starts seeing patterns in the lungs that look like abdominal injuries. So the RATIC team had to build an automated pipeline to crop the scans.
Standardize it.
Right. They standardized the view to go from the mid-heart down to the proximal femur, so the thigh bone.
So they basically gave the AI blinders so it would only focus on the relevant abdominal area?
Right. Eliminate the distractions. But that wasn't the only data problem. There was also the issue of class imbalance.
Class imbalance. Sounds like a statistics term.
It is. But the concept is simple. Thankfully for humanity, most people who get scanned after a car crash are actually okay.
Which is good for the patients.
Great for patients. Terrible for training AI. If 90% of your scans are negative, meaning no injury, the AI gets lazy.
Yeah.
It learns that if it just guesses healthy every single time, it will be right 90% of the time.
That's a smart but useless AI. Everyone is fine. Look how accurate I am.
Exactly. So the organizing committee had to be proactive. They asked the contributing hospitals to go dig through their archives. They specifically asked them to find and submit positive cases.
People who are actually hurt.
Right, to enrich the data set.
So they artificially balanced the scales so the AI would actually have to learn what an injury looks like.
Precisely. Even then, it remained a challenge, but that enrichment was vital to making the training effective.
So they built this incredible resource. 43 experts, thousands of scans, 6 continents, curated, cropped, and segmented.
Oh.
But they didn't just put it on a hard drive and shelf it.
No.
They turned it into a competition.
The RSNA 2023 Abdominal Trauma Detection Competition, they hosted it on Kaggle, which is the world's biggest platform for data science competition.
And the response was huge, right?
Massive. Over 1,500 teams from around the world.
Wow.
These are teams building models, tweaking algorithms, all trying to get the highest accuracy score on this RATIC data.
And this brings us to the big question. What is the end game here? Are we building a robo-radiologist? Is the goal to replace the doctor?
No. And I cannot stress this enough. If you read the paper, if you talk to the organizers, that is not the goal.
Okay.
The goal is two things: triage and augmentation.
Let's break those down. Triage.
Imagine that ER queue again. You have 20 unread scans. The radiologist is busy with a stroke patient. A trauma patient is waiting in the hall.
Right.
If an AI can process those scans in the background and flag scan number 14 saying high-grade liver injury or active bleeding detected, that patient moves to the front of the line.
So it's not making the final diagnosis, it's sorting the mail. It's saying, open this one first.
Exactly. That speed saves lives. Minutes matter.
And augmentation.
That's about the second set of eyes. Remember, radiologists are human. They get tired. It might be 3:00 a.m. A bowel injury, like we said, is incredibly subtle, just a little mistiness in the fat. If the AI can highlight that area and say, hey, doctor, double check this loop of bowel, it helps the human catch something they might have missed.
It's the wingman.
It's the wingman. It's not checking the pilot out of the seat. It's helping them fly the plane safely through a storm.
I love that. So let's wrap this up. We started with a global problem trauma deaths. We looked at the logistical feat of coordinating 23 global hospitals. We saw the technical solution, this curated, voted upon, incredibly diverse data set.
And the so what here is that the RATIC dataset is now free. It is available for researchers. It is the bedrock upon which the next generation of trauma tools will be built.
The competition was just the starting gun.
Exactly.
It's amazing to think that a bunch of CT scans and spreadsheets could essentially change the future of emergency medicine.
It really is. And, we often talk about the risks of AI. We worry about the algorithm making a mistake.
And those are valid concerns.
They are valid concerns in data science. But looking at this, I'm left with a different thought.
What's that?
In a field where time is the enemy and where human variability is so high, is the greater risk actually not using these tools? If an algorithm trained on the collective wisdom of 43 experts can spot a bleed 10 minutes faster than a tired human, that isn't just technology, that is a lifeline.
That is a powerful thought. And it makes you wonder, what other medical emergencies are just one great data set away from being solved?
That is the question we should all be asking.
Thanks for listening to this deep dive. We'll catch you on the next one.